Welcome to Siren's Hot Topics discussion today for the month of October. We're very, very excited to be having a conversation about North Carolina's Healthy Opportunities Pilots evaluation results that came out last spring. Before we get started, just a reminder that this webinar is being recorded and a link to the presentation will be sent to all people who registered. It will also be posted on our website when it's available. It's usually, it should be by the beginning of next week. So yes, the webinar is being recorded. We also welcome your questions and comments. We want to make this an interactive session. Please use the Q&A feature to ask your questions. The Q&A is available to you at the bottom. It says Q&A. And if you don't see it, click under the more and it should show up. So that's a great place to ask your questions. And we will try to get to as many questions as possible in the hour. Second thing I want to mention is we are very excited that we are going to be hosting another national research meeting in 2025. This is going to be happening in early February 2nd through 4th in San Diego, California, and registration will be opening very soon. Right now, we're accepting travel scholarship applications until October 21st. So these are for individuals who would not otherwise be able to go to the meeting, and a preference will be given to individuals who are underrepresented, who are from groups, racial ethnic groups, or socio-demographic groups that are underrepresented in research. If you want more information, the link is in the chat about the scholarship. And this meeting is going to be a fabulous opportunity to get together with other people who are doing research in this space, who are implementing social care interventions, to talk about what's new, what we know, and how do we advance the research. We hope that many of you will join us. And now I would like to introduce our three fabulous speakers today. We will first be hearing from Dr. Seth Berkowitz, who is an associate professor of medicine at the University of California School of Medicine and is the lead evaluator for the Healthy Opportunities Pilots. Then we will have two speakers from the Catholic Charities of the Diocese of Raleigh, Emily Hart, who is the Cape Fear Regional Director, and Daniel Altano, who is the Director of Communications and Disaster Services. Okay, so just a quick reminder, if you've got questions, please ask them in the Q&A at any point during the conversation, and then we'll get to them at the end. I will now turn it over to Seth to start us off. Seth, all yours.
All right. Thanks, Carolyn. So I'm Seth Berkowitz, and I am not going to be using any slides, so just kind of winging it here. But I've got some notes in front of me to help me stay on track. So I want to do a couple things. I want to give some background about the Healthy Opportunities Pilots, and then how they work. What the sort of overall structure is, and then talk about some of the interim evaluation results. Before I do that, though, I guess I should tell you guys a little bit about my role in the project. So I'm a primary care doctor in my clinical work and a researcher who studies social determinants of health and health-related social needs. And my specific role in the pilots is that I'm the lead evaluator for the Healthy Opportunities Pilots part of the North Carolina Medicaid 1115 waiver. As many people know, Medicaid 1115 waivers often have multiple components, and so there are sort of different evaluation efforts for different components. All of those are based at the Health Services Research Shop at UNC, which is called the Shep Center. So I'm the evaluator for the Healthy Opportunities Pilots piece of that. But there are other pieces related to Medicaid transformation, moving from fee-for-service to managed care, substance use disorder, and other elements as well that I'm not as involved in those aspects of. The Healthy Opportunities Pilots have been in development really since about 2016. Were approved as part of a 1115 waiver in 2018, and then sort of designed finalized in 2019. Services were supposed to begin in late 2020, winter 2021. As some of y'all may recall, other things were going on in both North Carolina and the country overall at that time related to the COVID public health emergency, and so services were did not start at that time and actually began in March of 2022. The full waiver period actually ends this month, so October of 2024. The 5-year total waiver period was from 2019 to 2024. The state of North Carolina has submitted a request to have a second waiver period, but that is still kind of in the works with CMS at this time. But the upshot of all of this is that the pilot services were delivered for a shorter period of time than was initially intended, so not starting until March of 2022, and had sort of a phase-in of services during that time period. As part of 1115 waivers, there are mandated CMS evaluations with a sort of pre-approved evaluation design. What I'm talking about today is what's called the interim evaluation. So these cover the results from the start of service delivery in March of 2022 until November of 2023. So a little under, maybe a little over, I should say, an 18-month period for that. Also, big caveat for all results that we're talking about here today. So we submitted the interim evaluation report to CMS in April of 2024. DHHS, the North Carolina Medicaid agency, posted that draft report on its website. So everything I'm talking about has been publicly posted by DHHS, but it is still a draft. It has not been officially approved by CMS. So all results are kind of subject to change, and there can be revisions and other things in the works. So definitely take everything I'm saying as preliminary and not final results. All right, so that's a bit of background. Let me also just talk a little bit about how the pilots work and are set up, at least from my perspective. As with many things, depending on the role that you have within them, you sort of are more aware of certain elements and maybe less aware of others. So there's certainly things I could be missing, but this is kind of how I think about them. So they're really designed as a collaboration between the Medicaid managed care plans, which we call PHPs, prepaid health plans in the state, a sort of community hub organization that is called a network lead, human services organizations, which we sometimes abbreviate to HSOs. We're actually delivering pilot services, and you'll hear more from a great HSO later in this webinar. And then the state as administering it, and then clinical and other community partners as well. As part of North Carolina's Medicaid transformation, all prepaid health plans are required to conduct screening for health-related social needs. In the pilot region, a common way that people make it in pilot regions, a common way that people make it into the pilots is through those screenings. So the one entry point is through a positive health-related social need as conducted by people's prepaid health plans. As I sort of alluded to, the pilots are not, services through the pilots are not available throughout the entire state of North Carolina. They're available in 3 pilot regions that were selected as part of a competitive procurement process by the Department of Health and Human Services in North Carolina. And so there are three regions across the state, one in Western North Carolina, which is area that's particularly hard hit by the after effects of Hurricane Helene, if people have been following that, and then 2 that are in the southern and eastern parts of North Carolina as well. In general, there's a fairly high representation of rural counties. North Carolina has a mix of rural and urban counties, but is a fairly rural state, and the pilot regions in particular are fairly rural in their composition, although there are urban areas included as well. So if you are a Medicaid beneficiary living within the pilot regions at sort of a county level is how it's determined, then you're potentially eligible for the pilots. Other eligibility criteria include both clinical and social risk factors. So the social risk factors are determined by the sort of standardized health-related social needs screen that is used in North Carolina, and those encompass needs like food, housing, transportation, interpersonal violence, and toxic stress needs. So everybody in the pilots reported at least one of those needs. And then there are clinical criteria that are based in sort of 4 big picture categories. So adults, pregnant individuals, and then there are two different categories within the childhood age range, one focusing on young children, so ages 0 to 3, and one focusing on the entire childhood period. And there are mixtures of clinical diagnoses, health service utilization outcomes like frequent emergency department visits, things like that, that allow for eligibility based on that. And the report has a nice table of all the different sort of nuances there. I mentioned that screening administered by the plans is kind of a primary way that people get into the pilot. So if people have a positive screen, they're generally referred to a plan-based care manager who then does an intake and works with individuals to determine what needs may be right for them, and then places referrals for services through a platform called NC Care 360. However, that's not the only way. North Carolina has taken what's called a no wrong door approach. And so if health-related social needs are uncovered in other settings, clinical settings, or human service organization settings outside of the pilots, people can also make it into the pilots in that way. So that's not the only way but that has been, and just looking at it, a common way that people have gotten in. Once people are enrolled in the pilots, there's sort of a standardized intake process, and then people are eligible for pilot services. These services cover domains related to the needs I mentioned. So there are food, housing, transportation, interpersonal violence, and toxic stress services, and also something that's called cross-domain services. And there's a standardized fee schedule that sort of sets out, details of what service is covered, any other qualifying factors, the amount that's reimbursed for it, and everything. NC Care 360 is one of the sort of key information technology tools that's used for the pilots. Referrals are managed through there. Payment tracking and invoices also come through there. Patients' reported needs are documented there. Not that some of that doesn't occur in other systems as well. And I think any of us who have worked in this area knows it's very complicated, and probably no system is really ideal for all circumstances. But the NC Care 360 platform has been sort of the IT backbone of the pilots. All right, so that's sort of how people get in, how they get services. And then I talked a little bit about organizations involved. So each region has sort of a hub organization, which we call a network lead, that is meant to establish and help support and manage a network of human services organizations that can provide the various services. So some human service organizations might provide a very wide range of services. Others might specialize in one or a small number of services, and individuals in the pilots can receive services from multiple organizations depending on what their specific needs and qualifications are and all those things. And so there's sort of a regional hub, or again, what we call a network lead, that manages this, one in each region. Our evaluation focused on a couple of different areas. One, you can sort of think of as the logistics, or the nuts and bolts: how many people are screened, how many people who are screened ultimately get into the pilots, how many receive services, what amount is spent, and those kinds of things. A separate area of evaluation involved comparing screening in the pilot regions and non-pilot regions. One of the sort of operating ideas was, you may not want to screen for health-related social needs if you don't have, good responses to it. And so in the pilot areas where there may be good responses to it, that may promote more screening than in other areas, even though screening is supposed to take place in all areas. We wanted to look at how health-related social needs changed after screening. So, one of the part of the logic model for improving health is that addressing these needs is sort of a mediator on that pathway. And so I wanted to look at changes that. We wanted to look at changes in clinical and participant reported outcomes. So those could be things like quality metrics, blood pressure, hemoglobin A1C control, or things that are more patient reported, like health-related quality of life, and those kinds of things. We wanted to look at changes in healthcare utilization, inpatient, outpatient, and emergency department visits being key ones. And then we wanted to look at spending, both spending on traditional medical care, and then also spending on the pilot services. For this interim evaluation, not all of the outcomes that we'll look at in the final or summative evaluation were we able to look at. So we focused on a more limited set of outcomes in the interim evaluation. In regards to the nuts and bolts piece, we found overall that the pilots are enrolling a pretty substantial number of people in delivering services. There were around 13,000 people who had received services through the pilots in that little more than 18-month period. The service, payment and delivery was being handled through NC Care. Service delivery doesn't go through NC Care 360, but invoicing and sort of recording of service delivery goes through NC Care 360. So that is actually a pretty major lift to set up a if not statewide, sort of pretty large scale system for communications around pilot services, invoicing, referrals, and all those things. There was slightly more screening in the pilot regions than in the non-pilot regions, which was sort of consistent with what we expected. However, there was probably room for improvement in both areas. So overall screening rates were something on the order of 10 to 15% of total Medicaid beneficiaries in the area. So many people remaining unscreened, or at least their screens were not recorded in the data systems that we were using. Some more to do there. We did find evidence that health-related social needs seem to do better for people who participated in the pilots than we think they would have done in the absence of the pilots. In particular, we think health-related social needs would have gotten worse, i.e. they would have had more needs or a higher probability of each of the individual needs. So that would have been higher in the counterfactual, sort of the absence of the pilots. So that was sort of, again, a key piece of the logic model. Our needs better as a result of pilot participation, and it looks like they were. In the clinical outcome category, that was probably the area that we had the least information on for the interim evaluation report, and so we really were not able to draw any firm conclusions. There was nothing that was negative or unfavorable, but we were just had not enough information to say whether the pilots were having an impact on any of the clinical outcomes that we were studying. And then in terms of utilization, we found that the pilots were pretty consistently associated with lower emergency department utilization than we anticipated would have happened in the absence of the pilots. This was both overall and across those sort of four subcategories of pilot eligibility: adults, pregnant individuals, and then two categories for children. Similarly, we found a suggestion of lower inpatient utilization. This was just barely not statistically significant in the overall findings. I think the p-value is 0.07. When looking at the adult subgroup, who were sort of at the highest risk of hospitalizations, though the results were statistically significant there, and then results were just more uncertain in the other subgroups, which are at relatively low risk of hospitalization, and so there were just few events for pregnant individuals and children in both the pilots and the non-pilot groups, and so that added a fair amount of uncertainty. So overall, it looked like there was lower hospitalization, and there sort of definitively was in adults with more uncertainty in pregnant individuals and children. And then finally, we looked at costs, including both spending on traditional medical care and spending on pilot services. And we found that there was lower cost. Well, we found sort of two things. So one, we found that there around the time of pilot enrollment was a time of higher spending. And this was about what was anticipated. We know from prior studies that the people often enroll in programs like the pilots or other programs to address health-related social needs around the time of what is sometimes called a triggering event. So, a change in health circumstances that might lead to an emergency department visit or a hospitalization or something like that. That is often associated with higher costs, and that's what we found. So if you look at sort of, the month of pilot enrollment and sort of the month before and the month after that time period, it was associated with higher than usual spending. But over time, we saw a decrease in spending associated with pilot participation. One question might be, well, is that just regression to the mean? If people have a triggering event, are their costs just naturally going to go down? But when we compare to other Medicaid beneficiaries who also report health-related social needs but live in non-pilot regions, so they're not eligible to get health-related social needs services from the pilots, although that doesn't necessarily mean that they don't get services from some other place, but are probably getting fewer services than the folks in the pilots. We still see a relatively greater decrease in costs in the pilot group than what we think would have happened in the absence of the pilots. And so that equated to an estimate of about $85 less spending trend, so a decrease per month than we think would have happened in the absence of the pilots. And if you add together both sort of the higher initial spending around the time of the triggering event and then the decreasing trend in spending, you get that at roughly month 5 after pilot participation, we think spending is about where it would have been in the absence of the pilots. And then beyond month 5, we think there's sort of lower overall spending, including both the spending on the pilot services and sort of traditional medical services than we think would have occurred in the absence of the pilots. And those are all analyses that were done using a comparative interrupted time series design, which we can talk more about in the Q&A if people are interested. And so overall, I thought the results were fairly positive. The big thing that I think was left out of this interim report, and it won't be left out of the summative report, in fact, that a collection is ongoing right now, is more on the perspective of participants. And so we have what I think is a pretty robust program relative to many 1115 waiver evaluations of doing both surveying and qualitative interviews with program participants in order to capture more about participant experience than is typically available in the kinds of data that are most commonly used to evaluate these programs, which are things like claims and administrative records. Those are certainly important, but for me as a primary care doctor, and I think probably for many of you guys, really the most important thing is patient experience, well-being, health considered holistically. And so that will be a key part of the summative evaluation, but we don't yet have results on that, but I think is really important to emphasize. The last piece I just want to say before turning things over is whenever you start talking about money, that often becomes people's focus. And, I think there are clearly positive results around spending here. Again, these are preliminary results. Our analyses do not include all the possible costs that you might consider. For example, spending that is not attributable to a specific individual. So capacity building funding for organizations or things like that is not included in these analyses, which are individual level analyses. They will be in the summative evaluation, but that's not included right now. So there's that caveat. But I think there's also just an important thing to think about what changes in healthcare spending mean. Changes in healthcare spending, could be positive or could be negative. If people were not previously getting care that they should have and were able to, then healthcare spending might go up. But I would argue that that's a good thing. People are able to get care that they weren't. Similarly, if you substantially decrease people's access to care, cut them off from being able to get care they should, healthcare spending might go down. But I would argue that that's a bad thing. People aren't getting the care they need. In this case, though, the path to lower healthcare spending probably doesn't go through that access pathway. There's nothing about the pilots in and of themselves that should substantially change the access to medical care and other things that people would have. And so the main pathway that you might see a decrease in healthcare spending is just that people's health is better, and so they need fewer health services. And so again, for me as more a primary care doctor than a bean counter, I sort of view the spending results as a likely reflection of improvements in health that the pilots are having. And that's important because health is a very multidimensional and difficult to measure construct. And so it's hard to have sort of a single indicator of is someone healthier or not? And certainly I don't think cost is that. But in this specific case, I do think the main way that we might expect to see the differences in spending that we do see is because people are actually getting healthier. And Excuse me, and I think that's a really positive thing, and shouldn't get underemphasized when people are sort of just doing the accounting and those kinds of things. There are real people here, and we're talking about the people in difficult social circumstances that maybe had things made a little bit better for them by this program, and that is what possibly translated into these differences in spending that we saw. But the spending number, I think, is not the real name of the game. The real name of the game is sort of improving health and well-being for people. So anyway, I'll stop there. And then Caroline, I wasn't sure if you wanted to do some questions now before turning it over, or do them all at the end.
Yeah, let's do some questions now. Thank you so much, Seth. That was a great summary and a lot of really fabulous information. So just going down the list, one of the first questions was about the screening tool being used to identify social determinants of health. Can you just say more about that to the extent that you know?
Yeah, so the state of North Carolina developed a screening tool and asked that be used. It is very similar to the Accountable Health Communities screening tool overall. I know in particular where there were sort of previously validated items like the food items and those kind of things, those came from the Hunger Vitals Sandwich, in turn came from the USDA Household Food Security Survey module. And so items are validated where possible and otherwise very comparable to items used in other states and sort of across the nation. And there is on the DHH website, I don't have to hand, but I could probably find fairly easily the screening tool, but it'll look pretty similar to the Accountable Health Communities screening tool if people are familiar with that one.
Great. Then another question, what percentage of those who have been eligible were actually participated in the pilot? Do you have a sense of that?
It's
Like the
difficult to know.
13,000 that you mentioned.
Yeah, it's difficult to know. So there are a couple ways. So it's hard to know what the number of people who would be eligible um, for the pilots out of the overall number of Medicaid beneficiaries in a region are, because of this combination of clinical and social risk factors that there isn't sort of pre-existing data on. So for example, we don't know the health related social needs status of all Medicaid beneficiaries. And so we don't know from there. Based on the overall level of screening, I think there are probably a good number of people who may have been eligible who were not screened and thus likely did not their needs did not come to attention, so did not get in for that reason. But we really don't have a good sense of what those percentages are, and honestly, even the magnitude. I think it's probably not a small number, but whether it's 20% or 80% or something like that, we really just don't have a good sense. So we can compare to the overall number of Medicaid beneficiaries in an area, but not all of those Medicaid beneficiaries would be eligible for the pilots because of these other criteria that are sort of layered on top.
Thank you for that.
I will. The one other thing I will say, another way to answer that question is of people who enrolled in the pilots, how many got services? So that's sort of a different step. And so around 90% of people who enrolled ultimately got at least one pilot service. So when you're in the program, a very high proportion of people got services. But we don't. The main thing we don't know, we sort of don't know what we don't know, if that makes sense. In that, how many people may have been eligible had their social needs come to attention, but they didn't.
Yeah. Wondering if you could put, how do you think about the results of this evaluation as compared to those of the Accountable Health Communities model? Specifically with that model, one of the results that was intriguing was that the evaluators found impacts on utilization and on costs or benefits for utilization and reductions in costs, but didn't see any changes in social risks. And you found changes in all of those. Any sense of why?
Yeah, I mean, I don't know exactly why. I mean, I'll say one thing that I think is a major difference in the design between Accountable Health Communities and North Carolina and the Healthy Opportunities Pilots in North Carolina is Healthy Opportunities Pilots pays for services, and Accountable Health Communities really did not put a lot of money into the actual service delivery itself. And so, I think a key feature of the design that's used in North Carolina is that there is this sort of standardized fee schedule. It's very clear like what each service will what the reimbursement is for that. And there are real Medicaid dollars going into those services, and so I think that is a pretty substantial difference in the way that was done. Whether that accounts for the differences in results, I don't know, but that certainly is an area that I think is worth looking into.
Okay, I'm going to ask just a couple more questions, and then we'll shift to Daniel.
Also, sorry, I would say one other thing too is I think, and this, yeah, you probably know more than me, Carolina, about this, but in accountable health, the other thing that North Carolina did put a good amount of resources into was capacity building. So not just paying for services on a sort of, in a marginal sense, like the next person or in a variable cost sense, but also trying to increase the capacity of organizations to deliver services. And my understanding is that in AHC, there was probably less spent in doing that, maybe some. I know it wasn't officially part of the program. I know some networks themselves, as part of agreements and coming together, may have had some funds there, but I think that was probably less emphasized in AHC than it was here. So in HOP, I mean.
Yeah. Okay. Do you have any sense of the ROI of this evaluation, comparing the potential cost savings to the costs of administering the program?
Yeah. Apologies in advance to the person who asked this question. I am going to take this opportunity, as I take every opportunity, to say that I really dislike the concept of ROI when used in this context. And the reason, and also I think that people who are in evaluating position or sort of health positions should take opportunities to push back against the concept of ROI, because anyway. The reason why, or one of the reasons why is investment is so in economics, when you talk about investment is a very special category of spending. It is not spending to achieve any outcome. It's spending to make more money. So when you invest in capital goods or a factory or something like that, you are spending money now with the idea that is going to make you more money later. And so the return on that investment, the amount of money that you make because of that investment, is a reasonable metric for that type of spending. The other main type of spending, though, is what you might call consumption spending. So that's spending where you're trying to achieve a specific purpose or get the use of a good or service. Most of the spending that I think we're talking about in this health-related social needs space, I think, is not investment spending in the sense that we're doing it to make us money. And in fact, almost no healthcare spending is really spending that I think we're doing to make us money, although it may indirectly have the impact of making people healthier and more productive and those kinds of things. We're doing it to buy goods and services that people need to be healthy, and whether that's a GLP-1 agent or an anti-amyloid drug for people with Alzheimer's disease or a food box for people with food insecurity and diabetes, the goal is to achieve sort of specific health goods. And so I think it's very appropriate to evaluate whether what you're spending your money on is achieving the objectives that you're spending, in this case, improving health in various ways and whatnot. So definitely not against evaluation, but I don't view what is really being done as an investment opportunity, i.e., this is what is going to make America wealthier or that kind of thing. There may be benefits as people are healthier, more productive, and overall, but I really see the point of this kind of spending is to improve health and health outcomes, and I think it should be evaluated on that basis.
Thanks, Seth. Okay, we still have some questions, but let's turn now to, we have a lot of questions. Let's turn now to Emily and Daniel to hear more about the program and how it worked on the ground. And yeah, turn it over to you now.
Thank you very much. I will go ahead and share my screen. Let me know when my screen is shared. Great. Thank you. So we'll start with just a couple of introductions. My name is Daniel Altano. I am the Director of Communications and Disaster Services for Catholic Charities of the Diocese of Raleigh. I've been with Catholic Charities for the past 10 years, working with them. and was really excited when this opportunity was presented to us for our agency to get involved and provide the services that Seth touched on a little bit and that we'll do a deeper dive into in our presentation. And then I'll let Emily introduce herself.
Good afternoon. My name is Emily Hart. I am the Regional Director for the Cape Fear region for Catholic Charities of the Diocese of Raleigh.
So the first thing I will share is just a little bit of a visual of what Seth had discussed around what those pilot areas look like in North Carolina. So this is the map of the entire state, and those 3 shaded areas are those 3 separate pilot areas. And then this next image shows kind of the overlap area for our agency, Catholic Charities of the Diocese of Raleigh. We serve about half the state of North Carolina, and we actually have 2 of the pilot areas included in that. So we are talking about services specifically today that we've conducted in the area that is shaded in green through the community care of the Lower Cape Fear. But we also did have an office operating in that yellow area for Access East, providing some of the Healthy Opportunities pilot services as well. And so I will be sharing specifically about the housing services that we provided. We got into this as a disaster agency. We have a home repair and rebuild program. We were hit with Hurricane Matthew and Hurricane Florence in 2016 and 2018. And so we grew a home repair program from that. But as work on that was starting to slow, we were continuing to look for ways that we could continue addressing housing needs in our community. And so the timing worked out well for us to pivot that program into offering the Healthy Opportunities pilot housing services. And so there are 3 specific housing services that we offer: inspections, home safety and accessibility services, and home remediation services. And so for the inspections, what we are doing is inspecting homes renters are going to move into, and ensure that those families are moving into safe living conditions. We don't want to be using the HOP pilot funds to put families in situations where those health risks are still going to be present, and we're not going to be able to address what the goal of the program is of keeping families safe. And so our staff are trained through HUD training to identify code issues and make sure that the housing situation that family is going to be placed in will be safe and stable for them when they move in. There is a collaborative approach to our part of the inspections and what the individual goes through. So inspections are paired with 2 other services for HOP renters. One is housing navigation, who provides some support. The individuals are tasked with finding the housing on themselves, but there are tips and guidance given by housing navigators to help them through that process and support it. The other pair is the financial aspect. The HOP program provides funding for a security deposit and first month's rent. And so there is another organization that will be doing that. So in this one service, there are 3 groups that are each coming together: the housing navigation, the financial assistance, and then our inspectors to help make sure that this is a successful place that the individual moves into. Then there are those 2 categories of repairs. There are home safety and accessibility and home remediation services. So the home safety and accessibility services are things like installing wheelchair ramps, making bathrooms ADA compliant, fixing leaking roofs, really things that we can do to change the structure that the individual is living in to make sure that they are able to stay safe with our older population, keep them safe in their homes for longer, and for anyone that has access needs, making sure that they don't hurt themselves if they are in a house or a rental unit that is not ADA compliant. For both of these categories, remediation and home safety and accessibility, we are working with both renters and homeowners. There are criteria within the program when working with renters that, especially on the home safety and accessibility, if we are investing money in a project, in a housing structure that is not owned by the client, we want to make sure when those changes are completed that the homeowner doesn't, or the renter doesn't get kicked out or the rent increased beyond what they can pay, since we are making the repairs to the landlord's property as opposed to the individual Medicaid recipient. And so there are certain agreements that we have individuals, the landlord sign, that limit how much rent can be increased once these repairs are made, and really protect that renter so that they can really benefit from these changes that we're making on the home. Then we also have remediation services, and the two that we've really addressed most frequently are dealing with mold remediation and pest eradication. Being in the Southeast, especially after a couple of hurricanes have come through, mold is a major issue for us. Many of these families are also living in units that would have what you call deferred maintenance, where they have leaking roofs, where they have windows that leak, doors that don't seal shut. And so that moisture comes in, seeps into walls and causes major issues, rooms that can't be lived in, coughing issues, respiratory issues, all of that can stem from that mold. And so we work to address that and then also look at pest eradication and making sure we're providing that safe, clean living environment. Individuals can be eligible for both of these categories. So there are many times that they will be paired together. If someone has a leaking roof, it doesn't make sense to go in and treat the mold, but leave the roof as leaking because the mold will just come back. And so with the setup, what's been great is that we can go in, receive the home safety and accessibility referral, get the roof repaired, and then follow that up with the mold remediation services and get that addressed. So these two really complement each other very well. We do have a good number of referrals that come over with both, and we're able to really make a big impact on the families that we're serving.
Our agency is also contracted to provide 2 food services. So we provide healthy food boxes for pickup and for delivery. I will say that the healthy food box for delivery is our most referred service. We are currently doing about 395 healthy food box deliveries per week. And usually that prescription is for 3 to 6 months. We do have members that roll back on and continue to receive that service. And really the purpose of the food box is to supplement daily food needs, but they're really designed to promote better nutrition and offer some nutritional educational materials on healthy eating. We do try to promote different materials, but also some healthy recipes that where the items will be found in that box so that families can also come together and share a meal together. Next slide. So there are some guidances on what the healthy food box should contain as far as quantities by food group, but also examples of what those could be, just to ensure that we're all HSOs are providing a quality, healthy food box, but also gives us a little bit of, I guess, flexibility and being able to include some client choice items, as well as making sure that we're sourcing foods locally. So we really try to do a lot of that with sourcing local foods, especially produce and things like that, being in an agricultural state. Next slide. Seth touched on this a little bit, but the capacity building funds were really crucial for our agency to really get started, right? We applied to be a part of the program in maybe August. We signed contracts in December and food services rolled out in March. And so it was a quick turnaround to be able to build up our infrastructure, both equipment and also staff expansion, to be able to meet the needs of the program, because this was kind of an add-on for us. Catholic Charities has been providing, as Dan mentioned, housing services. for some time, and we've been in the food nutrition world for several decades, but this was something that we wanted to dedicate more time and attention to be able to receive the referrals that were coming our way. I think one of the things that the capacity building funds really helped smaller agencies and church ministries and more grassroots organizations who, maybe have a smaller, less robust infrastructure. This really helped them to be able to provide the services that they're contracted to do.
And then one other thing I'll add that was really helpful from the capacity building funds was really giving us the confidence to say yes to participate in the program, especially with making those commitments to hire staff. As it was a little bit of a slow rollout, and there was uncertainty around would the reimbursement rates cover our costs? What does sustainability in the program for these HSO organizations look like? Having the capacity building funds to cover those staffing costs while all of that was figured out, knowing that we had that runway of funding covered to get more efficient, to get those referrals coming in and closing the cases at the pace and rate that we need to be able to make the program sustainable, really was a very important cushion when trying to pitch this to our board, our CEO, our finance director, everyone that is ensuring the future success of Catholic Charities. And as you saw, we're a fairly large organization. We could have absorbed some challenges a little bit more, but for those especially smaller grassroots that know their community so well and really are valuable participants in here, having that for everyone was really valuable in getting some groups up and off the ground. So that was great that they included that in the program plan. And so we're going to touch on something that Seth touched on as well, of that why do we do this question. And when we've given similar presentations to other people, we have talked about that dollar and cents difference that it gets reported out, that $85 a month number. But especially for us as an HSO, that is not part of our mission. Our mission is not to keep health costs low. Our mission is to help change people's lives. And we've been able to do that. And so one story that I will share is we had a family who we got a remediation referral for. And so because of their rodent issues in the home, they had an 8-year-old daughter who never invited friends over to her house. She didn't want people to see where she was living. She didn't want people to experience that, and just didn't invite people over. And so just picturing what that means for a child wanting to play, wanting to have your friends over and not being able to accomplish that. The timing worked out for the remediation referral where we were able to get pest eradication out there, get that under control. And then this 8-year-old girl was able to have a birthday party with her friends at her home for the very first time in her life. That's not going to show up on any aggregate data report that's being run. But when Seth talks about it's not an investment for a return, but for that consumption and what do we do to improve people's lives, that is the story that kind of sits close to my heart when we had our staff share that with me. And so that really is something that can easily be forgotten in the dollar and cents talk, but is something we want to make sure gets heard.
I'll share one high-level success I think that we've seen with the healthy food box deliveries. I think the deliveries have allowed us to go into people's homes and kind of be the eyes and the boots on the ground into people's situations to really help advocate for members to also access the other 28 different services should there be a need. And like having that beautiful just partnership with our network leads and the care managers who send the referrals on behalf of those members, and just being able to be the eyes. I know that's something that our drivers definitely really appreciate, being able to offer families their services through that in that way. I'll share another housing success story. I think he was actually our very first referral for housing for safety, accessibility, modifications. And he was a young gentleman in his 30s who had had a stroke and became paralyzed on one side and was wheelchair bound. But he lived in a duplex that had about 4 steps to his front door. So he was really trapped on his porch. There would be times when he would go out and just kind of throw himself out of his chair and wait for someone to go by to help him back into the chair to be able to go out and actually leave his home. Like I think he felt really super trapped. And so that was our very first hub housing client. We were able to get him something as simple as a ramp to be able to go in and out as he pleases as a 30-year-old man. So that was another win for us and for him.
And so that's kind of where we wanted to leave things, and then make sure that we definitely left time for questions, and thank everyone for being a part of this and wanting to learn about what we have going on and what we're attempting to accomplish here in North Carolina.
Great. Daniel and Emily, thank you so much for giving us more of that boots on the ground kind of sense of the program. We've got a lot of questions in here, so I'm going to try to get to as many as possible. One that's come up a few times, and I'd be curious to hear all of your responses to it, is this question of, well, Seth, from the evaluation perspective, were you able to see whether there's some services that seem more effective than others? Like or were you just looking at it as a whole?
Yeah, that's a great question. So we did explicitly look at that, and one of the goals of the pilots was to identify if there were some, of this menu of services that seem to be working better than others. With the caveat that this is interim, and so sample sizes may be too small to detect some differences in other things. We actually really did not see a lot of differences between services. That does not necessarily mean that there aren't differences between services in terms of what situation they might be used in. It could reflect that the participants and the care managers are good at choosing out of the menu of options the services that are likely to work for them in their circumstances. And so, to my mind, it sort of support the fact that we didn't see big differences based on, comparing some food services to other food services, prepared meals versus a food box or a food subsidy, that kind of thing. It kind of supports the idea of having a broader menu of options and letting people kind of choose what may work best for their circumstances, and also just reflecting the fact that in different parts of the state, different services are going to be available and may work better for some people than others. And so again, having that flexibility and allowing an element of choice and discretion may itself be valuable. So we did look, and we'll look again in the summative evaluation, but so far we really have not found clear cut cases where some type of service within a domain was clearly better than another.
Emily and Daniel, any reactions to that question? Like from your perspective, administering the program, you mentioned that the food boxes are the things that are most frequently requested. Any other sense of like differences between the different services in terms of need and utility?
I think one thing I'll share that Emily touched on a little bit already is the idea of having the different touch points to get into the program. And then maybe you go in for one service, but then from someone that's interacting with that services and gets more in touch with the person closer to it, identifies, hey, I know I'm here for this, but I see X, Y, and Z. Talk to your care manager about getting that as well. And as Emily said it there, food delivery drivers see that, and then our staff see that too, because they are going into these homes to make the repairs, to complete the inspections. They're talking to the individuals. And so they're just sometimes that you share more things in person than over the phone. Maybe you didn't think to talk about it the first time, but now that you're being asked questions the second time, you're a little bit more open to sharing information. And so being able to have multiple ways to get into the program and get connected to other services, I think is really valuable.
Another question, did you see in the evaluation, Seth, any differences in terms of by race, ethnicity, or age, or any other kind of, or by region, any differences in terms of impacts?
We haven't conducted analyses to look at those types of differences at this point, largely due to sample sizes in the interim evaluation, and again because services were delivered for a shorter than anticipated period of time. For the subgroups we looked at were those major eligibility categories, but other subgroups beyond that, we have not conducted those analyses largely for sample size reasons.
I think that there are questions around the way that the payments happen to the HSO. So I wonder if you could say a little bit more about that. Did you bill? How was that? Who paid? How?
I can tell you my perspective, but I would actually be interested to hear from Emily and Daniel as well. So again, we're on the outcomes evaluation side, so not the kind of day-to-day operation side. So I may not be attuned to some of these things. My understanding is that invoices, although there may be other ways as well, but are generally placed through the NC Care 360 platform. Payments come from the prepaid health plans to the human services organizations. So basically, a plan will pay an organization for services after they're delivered. In most cases, these are, I guess I should say, payments for marginal services, so ongoing services, different than capacity building or administrative payments that might be on a per person per month basis or something like that. But for sort of direct service payments, there's usually invoicing through NC Care 360 and then payment from the plans to the organizations. Ultimately, the source of funding is Medicaid funds, so it's the state to the plans in some big picture sense, and then plans based on specific services is my big picture understanding of it.
That's
So
accurate. Oh, go ahead, Emily.
Yeah, I was going to say we invoice for every single service that we provide. So every single food box for every single member has its own invoice that is sent to our network lead for them to review before they push that to payer. We all have timelines that has to operate, has to happen within. And then the payer can also reject or accept it and then pay it.
And the one thing I'll add, just going back to those capacity building grants, it's a long process to get reimbursed for some of these funds. And so that having that float of when you pay for the service and when you're on the hook as an HSO versus when you get that reimbursement or the payment from the invoice can take some time. And so they have set things up, especially with some of the smaller nonprofits, to be inclusive, setting up some funds to have that help with that cash flow between when the funds need to be set up or sent out and the reimbursement timeframe. So that's been really helpful for getting more groups to build capacity and be able to participate.
Great. One super quick question as we're ending. There are a couple of questions about this in the chat. How did people get, where did the screening happen to kind of get people into these programs? Was this happening just in healthcare settings? Was it happening in all sorts of settings?
Well, so again, there was a sort of no wrong door approach. So the ultimate answer is that there are a number of different settings that can happen in. I do think a strength of the approach that was used in North Carolina is it really did not have to involve the healthcare setting. It was not dependent on people going in for visits to getting screened. There was supposed to be a good faith, and to my knowledge, all the plans met this. Not trying to cast doubt or anything. But I think the contractual language is that the plans would make a good faith effort to screen their beneficiaries for health-related social needs. And so it was generally, I believe, a telephonic or other form of mailed electronic outreach to do screening. And so a lot of the screening was independent of a clinical encounter, which I think helped reach more people, basically. But overall, there are a lot of different sites. Some certainly was based in clinical encounters, and some was based in other community organizations that, and in fact, North Carolina had a program to encourage other community organizations overall to increase awareness of HOP and be able to send referrals and that kind of thing as well. So it really was a kind of no wrong door approach, but a lot of the screening was not connected to clinical encounters.
Great. Well, unfortunately, I can't believe it that we're already at time. Thank you so much to our speakers. Thank you so much to all of you attendees. I do want to thank especially Emily and Daniel who are participating in response to Helene. So thank you for making the time to talk to us, and our thoughts go to all of you in North Carolina. That's it. We'll have further webinars later this fall, so stay tuned, and we hope to see many of you at our conference in February. Hope everybody has a good rest of their day.